So welcome back. I'm Angelo Sinopoli, one of the co-chairs of PTAC. At this time, I'm excited to welcome the experts for our roundtable panel discussion, who will share provider perspectives on improving outcomes for patients with complex chronic conditions or serious illness in total cost of care models. You can find their full bios and slides on the ASPE PTAC website. At this time, I ask our panelists to go ahead and turn their videos on if you haven't already done so. I'll briefly introduce each of our guests and then give them a few minutes each to introduce themselves. After all 4 introductions, we'll have plenty of time to ask questions and engage in what we hope will be a robust discussion. So first, we have Dr. Matthew Wayne, who is the Chief Medical Officer of CommuniCare. Welcome, Matt.
Thank you. Thank you for having me today. I'll spend just a couple minutes giving a little background, and I look forward to our discussion. I'm Chief Medical Officer for CommuniCare family of companies and Personalized Health Partners. CommuniCare is actually a family-owned business, and as you can see from the logo, it's our 40th year in existence. Started with a couple nursing homes in Cincinnati and has since expanded to about 130 skilled facilities in 7 states. Personalized Health Partners, or PHP, is CommuniCare's medical practice. And at present, we started that practice about 4 years ago. At present, it includes about 12 full-time primary care physicians. We actually have expanded into behavioral health and physiatry as well. And we have about 100 plus nurse practitioners that support the team. Of note, and I think one of the things that has accelerated our kind of transition to value-based is that about 25% of our residents on any given day are in some sort of capitated capitation of care model, specifically institutional special needs plan, as well as we have a high needs ACO reach. And that really helps to kind of provide a motivation to transform and change the way we engage both in care and how we're engaging our residents. Just real brief background about myself. I'm board certified in internal medicine and geriatric medicine. I've been Chief Medical Officer for about 15 plus years, 9 with CommuniCare. I actually, as a background, and I'm certainly happy to speak to it if the need rises, but I have been a Chief Medical Officer for a successful ACO called New Health Collaborative in the Akron market. We had about 20,000 Medicare shared savings participants in that ACO, as well as engaging in other value-based contracts with some managed care plans. You can go ahead to the next slide. As far as key takeaways, and again, I want to start very basically, but again, more strategic than tactics. I think we have some time to get into tactics, but strategically, I think sometimes we overcomplicate this. And when you distill this down, everything that we do is based on creating a connection or relationship with our patients, with our residents. That drives everything else we do. And so the way in which we engage and the time in which we take to engage is predicated on forming those connections. And we can see that where these connections form in meaningful ways, good things tend to follow. And so what happens, first you start with that foundation of the relationship. Once that's established, obviously then we seek to define goals of care, understanding our patients, what matters most to them in the context of their chronic disease and their health concerns, and then how does that then translate into a better understanding of goals or care, what they want and what they don't want. Beyond the advanced care planning, we embrace best practices in chronic disease management. While there is a lot of art in medicine, there really shouldn't be 25 different ways to take care of heart failure or diabetes. And so we should embrace best practices. We should agree on those best practices as a medical practice, and then we should hold ourselves accountable to those best practices. And then last, I think accessibility, right? I mean, so it doesn't get more complicated than that, but we need to be present and there when our patients need us, as opposed to when is most convenient for us. So everything we do as far as our availability and as far as how we build our schedules is geared around that flexibility, so that obviously we can see folks routinely when needed, but when the issue arises and they need to be seen more urgently, we have the flexibility to do so in almost all cases. So again, I look forward to, thank you for having me, and I look forward to having further discussions this afternoon.
Great. Thank you, Matt. Next, we have Dr. David Gellis, who's the Vice President and National Medical Director for Medicare Population Health Programs at One Medical Senior Health. Welcome, Dave.
Thanks. I'm going to try to make the title as much of a tongue twister as possible. Thanks for having me. I'm excited to be here, and are already hearing resonance with what Dr. Wayne was sharing previously. So I've worked at Iora Health, which became One Medical and is now part of Amazon Health for over 12 years now, and helped to practice in and grow what's become a nationally scaled care model built around senior focused practices that's almost exclusively operating under global capitated risk. Started in Medicare Advantage, and then was one of the early joiners in ACO REACH and the direct contracting program. Our care model embeds population health in the practice team. Again, along Dr. Wayne's comments, it's about relationships with patients in primary care and how we can leverage that to improve outcomes and decrease cost over time. But in addition to that robust care team, which has behavioral health and health coaches and lower panel sizes, we're also increasingly deploying home-based and virtual programs around that for some of the more complex high needs patients. That's the topic today. As I said, we joined the GPDC ACO REACH model in the first round, and today that comprises about 15,000 of our total risk lives, and we've had really great results on quality and cost savings. Next slide. I went a little bit more technocratic with my takeaways, and we can talk more about the patients and the longitudinal journeys that are the heart of this. But I do think for us, global risk contracts has been the key to being able to make those investments. See our patients more often, bring those services to bear, and focus on health equity. But to do that, these programs need to have some key features, and we can go into more on this. We need to see stability and predictability. It takes a long time to invest in changing folks' health and supporting them. We need benchmarks that reflect that acuity. We need to think about quality metrics that are specifically appropriate for a complex population. ACO REACH has been a great structure to help bring what we have been doing in Medicare Advantage, and honestly we've been doing for traditional Medicare patients as well, but without a business model previously. And there's a lot of structures there to align incentives for patients, for PCPs, for specialists, for the broader system. But I think there's some ways that through payment and program design, CMS could strengthen those levers. Then finally, we have to talk about AI and ML somewhere. And I do think, there's a real role, particularly in supporting the care for complex patients. This is not going to be the chatbot solution to, solve a runny nose easily, over a video chat. But I do think in identifying, stratifying, and just handling the massive amounts of information that a complex patient generates and accrues across the health system, those technologies are going to be key. So happy to talk more about any of that or anything else.
Great. Thank you, David. Next, we have Dr. Cheryl Phillips, who's a program consultant at the John A. Hartford Foundation. Welcome, Cheryl. You're here in person.
Thank you. I'm delighted to be here in person. And I won't go through my resume because I'm kind of the grandmother, I think, on this panel in terms of both experience and age, but I'm not ageist because I'm proud of it. But I've had just the absolute pleasure and delight of a career that's intersected clinical work, healthcare systems, health policy, and payors. My clinical work, and Walter and I have some wonderful intersections as well, has been post-acute long-term care. Also of interest to our prior panel, I was the first chief medical officer of ONLOC, which is originator of the PACE program. So I have deep roots in looking at models of care. Most recently, I was the president and CEO of the Special Needs Plan Alliance, and we've heard some references to special needs plans, whether they are chronic care special needs plans, institutional special needs plans, or duly eligible special needs plans, again, subset of Medicare Advantage. And so I've had the ability of looking at payment, regulation, delivery systems, all with the intent of focusing on the highest risk, highest needs individuals. We can go to the next slide. Because, and Matt, you touched on this a little bit. So 30 years ago, I was working with a healthcare system in Northern California, trying to teach them about high risk, high needs, complex care individuals. And the same principles and premises, with the exception of AI. So we didn't have a lot of AI 30 years ago, but the concepts are still the same. And in fact, I would argue that our complex care has become far too complex. And we've touched on so many reasons throughout this panel earlier today, whether it is the plethora of disconnect. I mean, the specialist work is phenomenal. Our integration of specialty providers is fragmented. Even if we're using the same cut and paste EHR, we're still not communicating well. Our team-based care is fragmented because it is multidisciplinary, not transdisciplinary, and I'll touch a little bit on that. And then we have a cacophony of what I call polymanagement syndrome, because we have all of these managers starting 30 years ago when we were looking at disease management, but even now when the care managers, care coordinators that are not yet integrated. So some of the key principles, and I'll move along quickly, and we've touched on them, but any strategy that we have has to have a targeting and identifying high risk, high needs populations. Even when we talk about those dually eligible, that's not a targeted population, because within that subset, there is such a heterogeneous mix of needs. We need truly value-based payment models. And while, yes, global payments are a step, if we have managed care that's nearly paying all of the clinicians a discounted fee for service, we have a different payment model from CMS to payers, but we haven't transformed delivery. And then when we talk about integration, and we've, again, in earlier panels talked about the whole person, the function of the social needs, the caregiver support. We can identify a lot of risk just by knowing who has whom to help care for them and where do they live. Meaningful team-based care, as I touched on, I think PACE is the ideal model of the transdisciplinary. Multidisciplinary is where we all chart in different parts of the medical record. Interdisciplinary is where we may talk to each other. Transdisciplinary is where we blur our perspectives and disciplines and have the individual or person at the center. We need to measure what matters. And I know that in the next panel, Dr. Blum's going to be talking about that. Ultimately, it has to be, and I'll look to the 4 M's from the John A. Hartford Foundation, focusing first on what matters. So goal-oriented care across our continuum that's built into our health record, that transcends all of our team-based care, all of our specialty services, so that it's all focused. And we need to have a meaningful basis of primary care. And that too was talked about earlier, that it's not just triage, it's not just referrals, but it's actually that coordination of holistic care. And we don't yet have a payment system that supports that. And so I'm looking forward to the next 30 years where we won't repeat the same conversations, but as we're starting to now start to look at form follows finance, we get what we measure, so we change what we can measure. How do we use those tools to really drive high needs complex care? Thank you.
Great, thank you. Those are great comments, Cheryl. So thank you for that. We also have Olivia Rogers, who's the Vice President and Chief Nursing Officer of the Visiting Nurse Association of Texas. Welcome, Olivia.
Hi, thank you so much for including me on the panel. And Dr. Phillips is definitely hard to follow, but my take on this is a little bit more pinpointed to one specific thing, which I'll share in a minute. But I am the Chief Nursing Officer at the Visiting Nurse Association of Texas, and we are a 90-year-old organization this year. And actually this year, we also celebrate our 40th birthday in hospice. So we have been a provider since 1984. We were part of the Medicare pilot before the Medicare benefit came into play. We currently have about 320 patients in 16 counties, both rural and urban. And going to the point of really the patients and residents in our area who are underserved and have really poor social determinants of health is our very large Meals on Wheels program. We serve 8,000 home delivered meals a day, hot meals. We say that it's more than a meal because we're actually asking questions oftentimes when we drop off those meals. How are you doing? Have you had any changes to your health? We developed an app by which DE drivers can enter information about the client that they're visiting. And if those needs are related to healthcare, we then have a ever-growing community health worker program. And health workers are employed then to go out into the community and visit those Meals on Wheels clients who have expressed that they have a high need clinically. Oftentimes that's something as simple as they have not seen a primary care physician in many years, their medications are maybe something that was prescribed in an emergency room. Often that's the case, and they don't have refills or a way to get them. They don't have transportation for access to healthcare and food insecurities. So this is a big push right now for the Visiting Nurse Association, because within our safety net as an organization, we have countless residents in Dallas and surround that are just really struggling. We also at VNA were a participant. This is what I'm going to talk about more in the next slide, but we were a participant in the model for the Medicare Care Choices model, which was to test essentially what I call community-based supportive palliative care, and done by hospice providers nationwide. We jumped in with both feet to that program, and I feel that it had a tremendous impact on our community. So I think this is a really brilliant way to address these really complex medically patients that are really struggling. Many of them are very, very ill, and they are not ready for hospice, or maybe don't ever want hospice, but they are falling in the gaps in a lot of cases and ending up in the emergency room and ending up in the hospital because they don't have that safety net of in-home supportive palliative care. MCCM addressed this in a beautiful way, and we were a participant in that program. We continue to provide supportive palliative care with our own program called the Care Choices model at VNA, and we have modeled it after our participation in the MCCM model. We can't do all of the things that we were doing in the MCCM model because of a lack of payment, but it really informed, to me, the best way to provide supportive palliative care. And I like what Dr. Wayne said about it's based on the relationship. That really taught us a valuable lesson that if you can establish a relationship with a patient, it improves their health outcomes. And they have someone to call 24/7. They know who their nurse is. They know who the physician on the team is, their social worker. That was why MCCM, in my opinion, worked. And it also set up best practices, as you said, so that it was not up to each individual provider how to provide supportive palliative care. There were strict guidelines from Medicare conditions of participation. We also were a participant in the ACO REACH model, and we continue to provide supportive palliative care to WellMed and their Medicare Advantage patients. Next slide. So one of my concerns from where I sit, running a fairly large hospice in these counties that we serve, is the late admissions to hospice, which can result in adverse impacts on patients and their families, as well as on Medicare spending. Patients who may need hospice, or at least need someone visiting them in their home, that is sort of that line between maybe home health and hospice. They're right in the middle. They are probably too sick for what home health can reasonably provide, or they've run their course of home health, but they're not ready for hospice yet. Maybe they're still pursuing chemotherapy or some other disease-directed therapy and treatment. They still need someone to help manage their care and to bring all of, like Dr. Phillips said, all of the specialists, all the providers together to actually coordinate what's going on with this patient as they decline. But unfortunately, we do that oftentimes way too late, and patients, when they are appropriate for hospice, are coming on in the final days. The average length of stay in 2021, according to NHPCO, was 17 days. We see that at our organization as well. But indeed, hospice does save Medicare a lot of money in the last year of life compared to beneficiaries who don't utilize the benefit. So one of the things that MCCM did is it allowed earlier access to the hospice benefit for those who want it. It's not everyone's desire to ever choose hospice, and that's okay. It's still, even if they didn't go to hospice while they were on the program, inpatient admissions decreased by 26%, outpatient emergency department visits decreased by 12%, aggressive treatment in the last 30 days of life decreased by 15%. It saved about $7,000 per enrollee on the MCCM program. And again, though, back to quality, which is the most important thing, I think, as it relates to any type of healthcare, but no more so than when our patients are so vulnerable toward the end of life. The surveys that went out for the families of those who were enrolled, patients and families in MCCM, showed that it improved patient satisfaction. They had more help, better help with advanced directives and planning. They were able to make their needs known and their final wishes known, and we were able to help them carry that out. As a benefit for those who wanted to utilize the hospice benefit, they were 18% more likely to use hospice if they were a participant in MCCM as if they were not. So my desire I would love to see a relaunch of MCCM in some way or form. I know there needed to be some changes to improve enrollment, also to get more hospices involved in the program. But we really saw that this was transformative in our community. And I think one of the things that's most important to me, again, is that it set up a standard of what in-home supportive palliative care would actually look like versus everyone kind of trying to create their own, which is not always in the best interest of the patient. Thank you so much.
Thank you for that. And thank you all for those great introductions and comments. We're going to move on to some questions, and we have a list of questions to ask you, but we have a question from the floor that I'd like to go ahead and start with. And so several of you have mentioned that you participate in REACH. And I think, David, you mentioned that REACH provides structures to align incentives across stakeholders, but the CMS should strengthen those levers. Can you comment about both of those comments?
Yeah, I mean, I think from just a first principle standpoint, global capitation with enhanced advanced primary care payments give us a lot of flexibility, right? And sort of puts the CMS program in a lot closer to equal playing field with MA in terms of some of the flexibilities and investments we can make. The beneficiary enhancements, the Part B cost share waivers, and just in general, safe harbors for value-based care have been instrumental and helpful in thinking about how we engage our patients, build new programs, and help them, coordinate care. I think some of the areas where can see additional development. One is just the program's scheduled to sunset in 2 years, and the sort of glide path from that to MSSP is difficult or unclear how that's going to work. And when you're talking about making investments in patients' health that take multiple years to play out. Now, in the case of some of the complex patients, some of those we can see a return sooner, just from the past comment. I mean, the end-of-life needs are tremendous and do often align better outcomes with lower cost. But in general, stability of the program and understanding where it's going is key. I think one of it's a funny challenge we've run into is as patients align and de-align to these programs, we've got, even within the CMS book, patients who we desire to kind of treat the same, and we're going to go and make investments, in their future outcomes. But from actually a legal standpoint, some of those flexibilities aren't there, and we run into inducement concerns, and we may not be able to fully take advantage of the safe harbors to provide care that we think is important and necessary. And so just we've actually run into that trouble with the Part B cost share waiver, just being able to track at the moment that someone is in, are they in the program? Are they going to be in the program? We're rapidly growing. We do a lot of voluntary alignment, and honestly, some of the fear of running into waiving services that we would not actually be at risk for from a legal standpoint was a challenge. I think the third is less about the program. It's not a fault of the program, but an area where we're looking for support. We have a significant number of lives under risk nationally, but in any given market, we're a small little P, in the world. And so there's a lot of interest on our end to, craft specialty contracts that align incentives there. And I love that framework around getting beyond multidisciplinary to transdisciplinary care. And we've done some experiments being in not just an EMR, but actually having multidisciplinary rounds with, our specialty partners. But our ability to actually be part of enough of a meaningful part of their book of business as a primary care ACO hasn't been great. And so is there a way to pool the resources and the buying power, or piggyback on other work from CMS? I think the shadow bundles are a good start to leveling the playing field and giving us some insight into how our specialist partners are performing. But I just would encourage CMS to continue to think about how to support primary care-led specialty integration versus moving on to exclusively working with the specialists to, craft care models there.
Great, thank you. And Olivia or anybody else who's got some reach experience, any additional comments?
Yeah, I'll add, it's Matt Wayne. Yeah, I think those comments were great. We actually, so again, and I want to couch these comments specifically. Our high needs ACO REACH program is predominantly focused on a post-acute long-term care setting, so nursing home setting. What's interesting is that if you look at and had kind of 5+ years of experience doing this, in a managed care population, typically the average cost of care on an annual basis for these beneficiaries is about $35,000 a year. If you look at traditional Medicare, it probably goes up to about $45,000 to $50,000 a year. Now, what I can tell you, and again, this is all comers, my organization, on any given day, we usually have an average daily census of about 13,000 residents living in our 130 communities. Now, that's all comers, so it could be traditional Medicare, it could be Medicaid only, it could be some combination of managed Medicare and managed Medicaid. But what I can tell you is of those 13,000 lives, based off of the current ACO REACH high needs criteria, we only have about 700 folks that qualify for that high needs ACO. So even taking a very large population, we've found that one of the biggest challenges and barriers is actually meeting that criteria. So it's interesting because we certainly could partner and start to grow with other entities, but I think that's where the models tend to get diluted, and you lose your core beliefs and values and approaches. And so we've found that some of these barriers are challenging to get to 1,000, to get beyond 1,000 residents to stay in the program. One of the things that I will note specifically in the post-acute and long-term care setting is that a lot of the risk adjustment to actually be part of the program is based off of Medicare claims that you don't traditionally see once someone is in a nursing home. So durable medical equipment and these types of things are more bundled in the nursing home, and so there's no way to capture it. And so what we found is, ironically enough, even though the nursing home resident is a higher cost resident from a medical standpoint, the risk adjustment doesn't necessarily show that, and we've had that challenge. So again, we love the program. We think the program really supports our transformation and delivering care in a different way, but we've just found some of the technical aspects of that program to be challenging to continue to remain viable within the program.
Thank you. Anybody else have comments? If not, we'll move on to our next question. So what are some effective approaches for proactively identifying high-cost patients with complex chronic conditions or serious illness and addressing those needs? Maybe we could start out with Cheryl.
Thank you. So as we started earlier in our conversation, targeting the populations are critical. And there have been a variety of tools, none that have been widely scaled or replicated, but it really gets down to not the sum of their diagnoses, the sum of their function burden, the sum of their social needs. And we hear lots of that from CMS right now of integrating social risk factors and social needs. It's also the sum of their living environment and their caregivers or their absence thereof. And so when we look at that overlaid with a core group of identified diagnostic categories that portend risk, that's when we start to really target that population that maybe is costly now. Lee, you raised that point earlier. Are they going to be costly just this year and then, revolve back to the mean, or are they actually going to continue to be costly? And I would argue that it's identifying the social, the caregiver, the environmental, and the functional risks on top of the categories of diagnosis. That's what we're missing predominantly in much of our risk adjustment. It's missing in most of our measurement. And I would dare say it's also missing in most of our global payment models.
Great, thank you for that. David, you want to take that question?
Yeah, just as you're speaking, thinking about where we need to go next, because we have not done this yet, but we've seen some success in using an ML model to help with this prediction. And, we have a custom built EMR. We were able to capture whatever we want in structured format wherever we want, which is wonderful. Doesn't help with the interoperability challenges, in the world, but we're able to get the information from our care teams. And then we're able to combine that with claims data and run a machine learning model, that sort of spits out predictions, looking specifically at a predictor of rising risk, so cost blooming, so to sort out some of the regression to the mean, and then pairing it with an outcome around mortality, specifically in the sort of polychronic multimorbid, not looking so much for advanced cancer, but COPD, CHF, who's going to get in trouble. And one of the nice things about the model is that it's got built-in explainability. So we're able to see what factors for a given patient, are rising to the top of the list and not, and we use that to identify them for various programs. I think the really interesting opportunity coming forward is how do we get to all of the social and all of the contextual stuff that we have. They're in the narrative notes. We've got health coaches are spending an hour with the patient and capturing who's at home and what's going on. And we've tried to force that into little button clicks in the EMR, but it just means one more button click that people don't want to do. And I think that's where generative AI, it's like not a huge leap to say point a GPT at the note and say, find me patients who are living alone or have talked about these various social determinants, and then be able to pull those things more prominently into the model. And so I think that's sort of probably where we're going next around that. But I do think having a system that gets beyond just claims and gets beyond provider gestalt, but incorporates those things has been helpful.
Right, very insightful. Any of the other panelists have anything they want to add to those?
I was going to add, just as a social services provider, we're a little bit unusual in that we're sort of on two ends of the spectrum. We have our hospice and palliative care, but then we also have this big Meals on Wheels operation. And it's not only the 8,000 clients that we deliver to their homes every day. We also serve another thousands, 3,000 maybe, meals to congregate sites, senior centers, and that kind of thing. So I wonder, I'm sure someone has thought of this, but to me, it would make sense to loop in these social service organizations into these models, because that's your high need population right there. All of our Meals on Wheels clients are seniors of one end or the other, and they are unable to provide meals for themselves. So generally, they have an unstable caregiving situation, or they live alone, or they don't have transportation. I mean, they check all the boxes of all the things that then lead to poor health outcomes. And we really saw this illustrated during COVID. This zip code Crescent right on the south end of Dallas had very poor health outcomes during COVID. But interestingly enough, we really started looking at that then. All the hospital systems, the county hospital system, all the safety net organizations were really looking at that. But that did not improve after COVID, and it was bad before COVID. And so I feel like these organizations like ourselves that are embedded in the community, that already have a relationship with these clients and can see where these things are headed. And again, it may not be the client, although we do have them that have metastatic end-stage cancer, but the ones who have totally uncontrolled diabetes, we know where those things are headed. We have access to those clients already, and we're not the only ones. We're a very, very large Meals on Wheels provider, but they're everywhere, right? They're in every county across the United States. and there's other social services too. This is just one example, but I think these are the people to really get in touch with because that's the high-risk population in the United States.
Right, thank you for that. Any other comments? Cheryl?
I'll just briefly add on to that because Olivia, you're so right. And with our community-based organizations, our payers don't know how to speak to them. They don't know how to exchange information. They don't know how to track outcomes. You can't ask a senior center what their NPI number is for their contracts for Medicare. So we speak different languages and we have a disconnect. And so payers will often, and I'll look at the special needs plans, they will also talk about the importance and the richness of community-based organizations, but they're flummoxed for how to do that. And then don't even get started with the poor primary care physician or physician networks that are like, we're not here to make all these coordinations work. So I think that's another mechanism that is essentially important, is create that knitting between the community-based organizations, the provider communities in the clinical side, and the payers.
Perfect. Thank you for all those comments. PTAC members, do y'all have any questions you want to follow up on this topic? If you do, just flip your thing. Walter?
I have several questions, but I'll just start with one. First, Matt, thank you so much for sharing some numbers around kind of what a total cost of care model can do with the appropriate care delivery model for this population of chronically complex, seriously ill patients. So I think I heard you say the traditional fee-for-service cost per capita for one of your patients in the nursing home is $45,000 to $50,000 per year, whereas under kind of a total cost of care model, whether it be ISNP or ACO REACH or some other model, you guys are coming in 20 to 30% below that. My question is, how are you doing that? Like, what kind of things are you doing to achieve those results?
Yeah, thanks for the question. I think it's a great question. It's interesting. I think a lot of the differences, again, the value-based models of care allow for a commitment to some, the infrastructure around transformative care. So some of it is very likely due to the support or infrastructure around our managed care plan. So, that's probably one of the traditional differences between a fee-for-service and a managed care. But I will tell you clinically, and this is what I have found most exciting, is that these programs have really allowed us to commit a much stronger infrastructure around kind of routine coordinated care, but then care also that provides access 24/7. And so it's interesting, Walter. If you look at, again, specifically post-acute and long-term care, the medical expectations in this setting go back, 30 to 50 years where, a physician visit is timely on admission if it occurs within the first 30 days. And then it's once a month for the first 90 and then every 60 days. And it's so ironic because you visit the residents most likely the day you're seeing them. They don't need to see you. Why are you here, doctor? It's nice to see you. But when they need you most, the regulations don't drive that responsiveness in that way. And so, I think these programs have created a commitment to having embedded care. So just having folks that pop in and pop out aren't good enough. And so we really look to embed that care. So we have a provider in our facilities anywhere. Again, obviously it varies by size and complexity, but I would say we typically are in a building between 3 and 5 days out of the week, depending on that size. So that predictability creates continuity. But the other thing is it's allowed us to invest in telehealth. And so we provide telehealth if we don't have a provider in the building that day, but we also provide our telehealth for after hours and weekends coverage as well. So our nurses have the ability to take a clinician actually to bedside and deliver care for change of condition. So again, within that fee-for-service or typical environment, it would be much more challenging to kind of make this type of commitment. But again, it goes back to the strategies that I talked about initially, and that is right. It really is. It's very basic. We have to connect and form these relationships, but we need to be accessible when our patients need us. And I think that's one of the most difficult challenges is do we as a medical practice or healthcare system have the flexibility to respond and be there when our patients need us the most?
Thank you for that, Larry.
Thanks to the panel for coming, and especially Cheryl for being here in person. So I'm gonna pick on you since you're here in person. Not pick, I'm gonna just pick your brain. You used the terms multi-specialty care versus transdisciplinary care, if I remember correctly. And you talked about the fragmentation of specialty care. As a specialist, I know all too well how the hub and spoke of the PCP to the specialists fails when you need trans-specialty communication and you can't go in and out. You should be going across. So expand a little bit on transdisciplinary care. Give us more detail, granularity on what you're talking about.
And when I think about it, it's also more than the physician disciplines. It's also the other disciplines, social work, nursing, pharmacy, physical therapy. But even looking within the specialty disciplines of physician care, first of all, having goal-oriented care, what matters to the person, that to me is the center of the hub, and that's often missing and rarely in any of the medical records. And, you know, when they see you for their gastroenterological issues, that's what you need to focus on. That's why they're there. But the problem is it may not connect. So I would, without creating, if I were queen, we have primary care wrong. If the primary care actually could function as the central high-risk, high-needs coordinator of services, that brings those voices together, starting at the hub with the goal of the person, what matters to them. We need to pay primary care differently because we've already talked about that in an earlier panel. I don't think that we have to spend a lot of time with the gastroenterologist and the oncologist and the cardiothoracic surgeon and the nephrologist all on the phone together because that's not realistic. But we need to have ways of aligning goals of care so that when we're looking at a treatment plan, it's not the sum of the person's diseases, it is the sum of their goals, looking at the broader picture. And that's what I think is the role of primary care that's missing right now. So it's not fault finding with any of our interdisciplinary providers. It's that we don't have a good platform and mechanism. So going back to what Matt was saying with whether it's iSNPs, the PACE program is a really good example. That center is the primary care team. And all of the services are still provided, they're still coordinated, they're still communicated, but it's based in a substantial and functional and meaningful primary care team that serves the person at the center. So while PACE is hard to scale, we've already challenged that, there are some important laboratory lessons, whether it's in nursing home settings or home and community-based care or hospital at home, that we have the hub as being truly owning that partnership with the patient. And I'm being too wordy, but I think that's where we've missed the boat. We have relegated primary care to triage and referral and a whole list of healthcare maintenance issues, which for this population has less and less meaning and relevance.
One follow-up though, we're dealing with a fixed sized pie. And so if we're increasing the size of the primary care pie to totally recreate primary care and to value it higher, it has to be paid for from the rest of the pie. In your experience, have you been able to succeed in getting specialists to agree to share some of their income with the primary care?
I think you know that answer. And whether it's at the RUC, the Resource Utilization Committee, and the AMA, nobody wants to give up their pie. But what we are seeing in this panel, and the whole reason we are here, is the current pie isn't feeding the right people. It is reinforcing a very, very fragmented and expensive subset of services that are not meeting the needs categorically on this higher risk, highest need chronic burdened population. So no, are the specialists rapidly excited about cutting the costs of cataracts or whatever? I mean, I'm not blaming. Yeah, I won't even blame any subspecialty. It's that we're spending a lot on the wrong pie.
Just to jump in for a second, I love the pie analogy. And that's why I think total cost of care global risk models are so important, is because they give me the pie first, right? I get the first bite of the pie. Now I'm giving 85% of that pie almost immediately on to specialists and hospitals and others, but just the accounting mechanism of having that flow through and putting my business partners eye in the position to, think about how do we change those incentives and pay differently. I think the problem is that all of this is still built on a chassis of fee for service, right? Like that is just, we do not have a way to account for and count the things. And that sort of goes back to some of my perverse frustrations with, star clause and inducement concerns there. It's like, I don't want to pay on a per paces basis for any of these things. I just want to say this is part of primary care and wrap my arms around it. And where we've been successful, like with behavioral health, and that's been very impactful. But I do think, putting the control in the starting position as running through risk-based organizations, if those organizations truly are provider-led and close to the patient and not just an insurance company, another name.
All that's been so well articulated. I appreciate that. And Jeannie, do you have another question?
I do. This is regarding, I think, going back to the pie. I'd love to hear from Dr. Gellis, Phillips, all of the panelists actually. So when we talk about the pie, what's often struck me is that we keep speaking to patient care focused providers, right? Whether it be primary care, specialty nursing, but if you actually look at the spend of the healthcare dollar, not a huge amount of it is in the physician seeing the patient or the nurse seeing the patient. There's a whole bunch of money in between. And I'd love to hear from the panelists, because I do think there's a world where the specialists and the primary care physicians can be compensated appropriately if we could take out the middle. And so I'd love to hear what administrative burden you feel is low-hanging fruit and can be decreased in order to save money.
I'll take a crack first. I mean, and going back to that comparison of traditional Medicare and our Medicare Advantage payers, the ACO REACH program has a 2% discount built in. I think it goes to 2.5 or 3 next year in the professional direct, versus Medicare Advantage is taking 15% of premium off the top, and it's going somewhere. Now, to Dr. Wayne's point, that's not all waste. Like there are things that end up better coordinated in a system in which a health plan is involved and does have some data and has flows, but I don't think all 15% of that. I think we can do better with that premium dollar. And why are my PCPs who are at risk and responsible for both cost and outcomes, why are they going through prior auth processes in the same way that others aren't in that incentive? I think you can reduce a tremendous amount of waste there. I think, again, the sort of the entire end-to-end on claims processing. I think the risk adjustment systems do create, I think there's value created. We have to have a risk adjustment system. I think it does make sure that risk groups are paying more attention to the chronic diseases that end up driving outcomes. But the amount of health plan and administrative waste that exists around that, and I think of annual wellness visits, that in-home wellness assessments that have no connection to care, and all of those dollars, and I do think there's just so much inherent complexity in the amount of the ways patients have to move through the systems that there's going to be administrative need there. And that's where I'm hopeful that technology can streamline parts of that. And that, even if we're not going to make the concept of alerting an insurance company that a patient's going for care disappear entirely, it could be much less frictionful and more efficient.
And I'll just add briefly, because I agree with everything that David said, but our payments are driven by settings for the most part, as we all know. So we have inherent redundancies in service, redundancies in administrative costs, because we're driving our services by the setting where we find the person to get the service. And then if they are episodes of service, even if they are home-based care like home health, we repeat the cycle of an episode of care, which is driven by the setting. So it's all the things that David mentioned, and it's our inherent structure of payment by setting, which is not dependent on the specialists or the primary care, as you pointed out. But then I would also argue we're the ones that are sending people to various settings because that's where the settings are. So we start the cycle all over again.
I would love to add to, I think it's a fantastic question. I agree with my two colleagues. That I think what I would like to add to it, and there is, right? I mean, there's so much inefficiency and potentially over waste in the system. It's interesting because the question is really targeted around how do we make sure that the dollars are flowing to the folks that are actually delivering care, doctors, nurse practitioners, nurses, social workers, et cetera. And I love that concept. The three areas, and again, it's not that it's unnecessary, but the way the system is built, it becomes inefficient and oftentimes wasteful. For the first area is contracting, right? Because our healthcare system is so complicated with multiple payers and multiple things to navigate, there is a lot that healthcare organizations invest around contracting. The second is actually finance, right? Because every organization's lifeblood is revenue. And so whatever programs are created, you need finance folks who understand how to make that revenue flow and to make sure that you stay afloat. So again, the more complicated things are to understand financially, I will say from this physician's perspective, it's horribly complicated. Like it's just so above of my ability. You need that infrastructure. And the last one, which is huge, and I think we do, folks around this table may have the ability to impact that, is reporting. So these programs have tremendous reporting demands, quality measures and data and outcomes that all require FTEs to go in, drill down, create reports, and send that information. So again, it isn't that reporting isn't necessary, but we need to be very thoughtful about what we're asking to report, because I can guarantee you there's a lot of this reporting that isn't effectively driving better care. And so I think those are three huge buckets where we can become much more efficient and reduce cost of care as it pertains to healthcare as a whole.
I would like to add on the note, kind of going back to the pie analogy, the pie for companies such as mine is often fairly fixed. You know, you can grow and there's some economies of scale, but when we look at people like DNA and providers all over the country who are serving a combination of urban and rural patients, but particularly your rural patients, which require quite a bit more time and effort and money to serve, and oftentimes are the highest need patients, that pie is fairly fixed. And so if we're going to add reporting for this or that, or if we're going to add audits for this or that, something else does have to be taken away because the pie is relatively the same size. What we don't want to do that adversely impacts the patient and family is hire more FTEs to manage back office functions and don't result in better care. It may result in protecting the organization from takebacks and that kind of thing, which is important. And of course we want to do that, but if you look at it from the seat of the patient, they never realize that additional money that's going toward this process. And meanwhile, we're not serving well some of the patients who are the highest need because either we can't find them, we don't know who they are. Kind of anecdotally, when we first started our program to sort of bridge the two halves of our company with the Meals on Wheels clients and what types of clinical care they may need, we immediately found out it was very, very hard to identify who the sickest clients were. And we know them, we see them every day, but still, it's not just a sum of their diagnoses. And how do we figure out who they are? And I think there has to be really some standardized way for providers, and I'm not a physician, but for all providers, for specialists and for PCPs and everybody, to identify who is going to be the costliest and who has the highest likelihood of dying in the next 6 months or a year or 5 years, so that we can put our money toward the right people who need it. And because I know the pie is one size, and but I love the analogy that it's not necessarily feeding the right people. those who are most vulnerable and live alone and that kind of thing.
Thank you. And Walter, you have a question?
All this talk about pies make me hungry. Actually, my question is going to be around risk stratification. I think our panelists have all kind of touched upon this, but Cheryl, I think you kind of brought this up in your slide. Individuals with serious illness are not the sum of their diagnoses. We kind of also heard similar themes in our first panel this morning as well. But unfortunately, that's how our current risk stratification system is based, right? That's the HCC score, the RAF score, and that's how payments are made, is the sum of their diagnoses. Like literally the sum of their diagnoses is what drives payment in value-based care. And so I guess, you mentioned the 4 M's, you mentioned integration of function, social needs, social support, behavioral health into all these assessments. Have you seen that done well in other places? And this is not just for you, it's for all of our panels. Is this being done somewhere else where the risk stratification is more robust and can be actually thought of in terms of making payments off of?
Well, I think we're early on this. I think we would all agree that using the RAF scores as they exist right now doesn't really get to this population. And David pointed out well, so we've had all of these systems that they're mining for HCCs. So they go out and they meet with people and they have long lists of diagnoses, but there's no record of it in the clinical care model. So how is it that that's driving cost? Putting that aside, I think that we're early on in this. I don't think that our current risk stratification captures the function, the behavioral health, the social, the caregiver needs and burdens of the individual that really is the sum total of their risk. I think we have lived and breathed by HEDIS measures for stars for health plans, in addition to the risk scores. And many of these measures, and I know I won't take away Carolyn Blum's discussion to follow in the panel, we aren't measuring what matters for this population. So we need new measurement to address appropriate risk scores. To that end, NCQA is very aware of that. CMS is aware of that. But we right now have a very different model of HEDIS and other quality measures. The second part, and you raised the question of where are the 4 M's? So the 4 M's coming from John A. Hartford Foundation, of which I'm a consultant, and IHI and the American Hospital Association, looking at really 4 domains of care. And there's an interesting, soon to be published report that came out of Oregon Health Science University, OHSU. They looked at the outcomes where 4 M's were used. The greatest impact was actually in the highest needs complex patients. So when the 4 M's were integrated into the medical record and across settings of care, hospital days went down, admission rates went down, total cost of care went down, and I won't take away the thunder of the paper that's going to be coming out. So there are ways for us to integrate, predominantly starting with goal-centered care, what matters, and then integrating the other elements, but we're not measuring the right things yet. So long answer.
Matt, anybody else have any other additions to that?
I think Cheryl had a wonderful response. The only thing I would add from a risk stratification that I think is underutilized is actually measures of frailty. And again, I show my bias as a geriatrician, but certainly frailty isn't necessarily exclusive to the post-acute and long-term care setting, but really fleshing out rather than chasing one's tail with cost or high cost patients or disease-based algorithms. But frailty at its core is just a measure of a collection of things impact on a person's ability to be independent. So measures of function, their activities of daily living, falls, skin issues, nutrition. And so incorporating that, because it doesn't matter. And it's interesting, if you look at in its purest sense, frailty really is age and diagnosis independent. So it really doesn't matter whether you have one severe illness or seven. It really, what matters most is its impact on the individual. And that truly is what should drive the services, the coordination, and the care to help bend the cost curve. So I think, trying to find measures that can be incorporated with risk adjustment that are frailty based, I think would be very helpful.
If I can add one thing to Dr. Wayne's points about frailty, everything you described is what you have to look at as the criteria for whether someone's hospice appropriate, right? So in the MCCM model, because it followed essentially the Medicare conditions of participation, the patients who were admitted to the MCCM model had to be hospice appropriate. And if relaunched, we could do the same thing or it could be different. But one of the benefits of that is you were measuring the Karnofsky and the FAST score and the Braden scale, and you're doing all of the things that you said, Dr. Wayne, to determine if they were appropriate for supportive palliative care, MCCM, or hospice. Even if you took that further upstream and patients were allowed to enter the program at a year or 18 months, the same is true, and that is you are immediately getting them access to that interdisciplinary or transdisciplinary team right away. Because based on those scores, which I think work, I think that all those scores are already created, and sometimes no need to reinvent the wheel. They are already out there, and I think they do work to predict someone's mortality.
All right, David.
No, nothing to add. I mean, other than in our ML model, one of the features that jumps predominantly is a frail, it's not the frail scale, but it's a claims derived, frail measure. And you can imagine this would also solve some of the issues of gaming in the risk adjustment systems to, make it a bit of a black box, right? Like you could go and have far too many, coefficients to build direct programs around. If there'd be some downsides to that, but if it got us a richer set of inputs around what's actually happening to a patient, I think it would improve the predictive accuracy and some of the policy problems.
Perfect, thank you. And I think Lauren has a question.
Thank you, Angelo. So we've heard some really great themes, the value of interdisciplinary teams, the need to have a really great responsive reaction system, so accessibility to the coordinated help, holistic assessment based on what matters to the client. I think another principle that's come out is the ability to really provide anticipatory or proactive disease management and anticipatory symptom management. And so I'd love to hear from each of you what you've seen to successfully translate that with providers, to teach it, to build it in. Which disciplines are most successful with that? And then how is that also playing out in the social realm? So, in my bias, I spend a lot of time in this space. So there's a correlation with anticipatory or proactive management of social complexity as well. So open it up from there. Anyone who wants to start.
Well, I'll jump in and then I'll let the other wise voices follow. First of all, and David has referred to this, I think the potential for AI is profound because I think it can start to draw from sources of information right now. Just like we have fragmented care, we have fragmented sources of information, and certainly fragmented integration of social information, as you would recognize. And so having a mechanism to pull that in, but even if we pull that in, then what do we do with it? Is it primary care? Is it the specialty? Is it the case manager at the health plan? So who owns that? And most importantly, who owns it in partnership with the person and or their family caregiver team? So I think we have some tools that will be yet developed. I think we have some hope for integrating this information. I'm very optimistic, and I'm not just being deferential to CMS, but the focus on looking at the whole person, looking at the integration of social needs and health equity as part of that holistic view is a starting point. We need to have measures that matter, and we need to have goal-oriented care, and then we need to bring all those voices together, and somebody needs to own it. And so that's all part of our journey that we're all talking together.
not to be a broken record, but I mean, the 4Ms have been incredibly useful for us as a framework. And again, I think it more important than the substance, it's a shared language to help reframe. I didn't learn medicine that way. I'm an internist, and I got exposed to listening, but I didn't have a way to communicate to others or to my patients, what I was learning from those sort of rich encounters. And really cool experience recently. We're working with an integrated cardiology program. It's virtual first, but we figured out ways to bridge the tech divide for our homebound patients with that. And we're now talking that language with them, right? When we're talking about it, this is not figuring out exactly what the valve area is and when that valve is going to get replaced, but what matters to the patient and what their mobility is and what else is going on. And so it's small, subscale, but I think again, it orients. We're all in it to help patients, right? And if we can sort of get out of the rubrics that we've been working under, we can make some progress.
Mine is short, but one thing I think we've done successfully in the last 2 years or so is we did partner with an HIE that after a while of us explaining why we felt we should be a part of the HIE and why it mattered if the hospital systems and providers knew that our clients were on Meals on Wheels, we finally were able to get a contract with an HIE. So now many of the big, most of the big systems in Dallas and surround, we serve 16 counties, can see that a patient is also on Meals on Wheels. And our hope is that that flag informs the care. It certainly informs it for us because, of course, we can then stratify patients based on how many ER visits they've had, how many hospitalizations, do they have a PCP. But our hope is also that we're feeding them information that they may not get in any other way, except acknowledging that them being on Meals would be a big driver for their health outcomes. So I think we are making progress. I didn't actually plan on talking about our Meals on Wheels program, but everything everyone has shared really makes me think that these social organizations are at the heart of predicting health outcomes, and how can we capture that?
I will just add, and I don't know that I have a great thought on what the answer is, but I think I can articulate what some of drives the behavior that you're observing. And I would contend that the fee for service, visit by visit mentality perpetuates that. Because if you think about it, right, it's all about what's happening in this moment and what I need to do to move on to my next patient. And so if the patient doesn't have complaints and they're feeling fine, even if they have a ton of risk factors, what's the incentive to actually engage in a lengthy conversation when you're being paid in 10 to 15-minute increments? And I think that's the challenge, right? We have to break that's what doesn't work. And so I think it would be easier to educate and get clinicians and engage patients around how it is important to be proactive and how we need to make sure you're on the right regimen and how important it is to take that medicine and to eat appropriately. But again, it doesn't fit into that every 10 to 15-minute visit mentality to help kind of keep someone moving along. And I think that's a big challenge. And it certainly speaks volume towards more of a capitated model where you can start to break down that fee for service mentality and really focus on what matters most in that time frame. Because you're right, so much of this could be averted with just a little bit better anticipation and proactiveness in how we deliver care and how we educate our patients.
Thank you. I think Jeannie has a question.
Yeah, this is a specific question for Olivia. One of the things we struggle with as we think through this is in a budget neutrality environment, how do you compensate for all the things that drive social needs? And it sounds like you guys have cracked the nut on it. So my question to you is the Wheels on Meals program, and I'm sure there's a transportation component. Is that a subcontract with the Meals on Wheels provider? Does some of that come out of your total cost of care funding? Like, how do you guys think about paying for some of the things that ultimately lead to good outcomes that aren't necessarily direct clinical care?
That's a great question, and I think our daily struggle. So we're a large nonprofit organization, so we do quite a bit of fundraising. We raise about $8 to $9 million a year to pay for Meals on Wheels for clients who have no payer source, and also to pay for hospice care for people who don't have a payer source. But in addition to that, we have a lot of state contracts for the Meals on Wheels themselves, and yes, there is enough of an overage there that we are able to partner with other organizations to support transportation. Our community health worker program is actually paid for out of some community block grants, and also we have very generous donors in Dallas who are very interested in testing these kind of pilots. And so we have a lot of reporting, of course, that we have to do, but it has shown so far to be very beneficial in keeping people out of the hospital, largely because that community health worker program is not a standalone program. Their goal is to connect these clients with the health care that they need. So we have developed very good relationships with some physician groups who make home visits. I'm drawing a blank on what that's called, visiting physician groups. So where nurse practitioners and physicians go out and see our clients rather than the unrealistic expectation that us telling our client that they need to be compliant with making a physician visit, when what that requires is them getting on multiple buses and then the DART train, and they have mobility issues, right? And they're, using a walker. And so we try to be we have a screening tool that we developed at BNA, and we use that. Our community health workers go out, they have them answer a lot of questions, but the clients are very engaged. We do not get a lot of pushback on it, I'll be honest. And that addresses their medication compliance, the fall risk, whether they live alone, caregiving status, advanced directives. I mean, just a myriad of things. And we use that then to communicate with someone, usually a house calls physician group, to communicate what their need is. Sometimes they need hospice and palliative care, but oftentimes they need something in between. But yes, the contracts that we have with the state, contracts we have with individual cities, like the city of Irving, which is a suburb of Dallas, has seen so much benefit from our community health worker program in Irving that they are paying for it on an ongoing basis, actually. So it's all one day at a time, and trying to find payers for this is not easy. However, the outcomes are so good that it's and every year in the budget, we look at how many more, and it's ever growing community health workers do we need to hire, and who's going to pay for it. But I was going to say this actually before you asked the question, that I think sometimes, and again, no one wants to give up their money, including me, right? I mean, I get that, but I think sometimes simplifying this back to something like a community health worker is incredibly vital to the success of these types of programs. It doesn't have to be someone who's formally trained in the practice of medicine or nursing or social work. It's someone who's willing to sit down and help them fill out a questionnaire that then can be communicated. We actually use those numbers from the questionnaire to come up with a score that tells us how high risk they are or not. And that type of employee is not as expensive as sending a nurse practitioner, for example. So it's a long-winded answer, but thank you for the question. I hope that answered it sufficiently.
Well, so who pays for this? Now we'll look at it from the Medicare Advantage side, which has its own pies. So everybody's eating pies these days. And the Medicare Advantage plans will say, we don't have new money. There's no extra payment for supplemental benefits, but it comes out of our quality bonuses. And our quality bonuses come out of our stars and our RAF scores or our HCCs. So we're going to maximize our HCCs. We're going to figure out how to do better data for our stars reporting so that we get better quality. So then we can use the difference between our bid, and anyways, that's where the money comes from. So we start this kind of odd circle of not really recognizing, and even MedPAC has pointed out, look, if these supplemental benefits are so important, let's step back and say, what are we paying for? How are we paying for it? Is it just something for MA? Does it apply to original Medicare? But right now we have these odd give and takes that probably drive unintended consequences in the other way, trying to get to the payment to these. When you truly have a global payment for the whole person, and we don't have many models, but there are examples, then you can start to look at why paying for transportation, as Olivia pointed out, makes a big difference, because they're actually getting to the doctor that we're paying for the outcomes for. But the only thing about global payment right now, and both David and Matt touched on this, it has to be down to the provider level, including the physicians. When you have a global payment that is merely paying PCPs to see 30 people a day, the global payment isn't driving the outcomes that we want. So there's not new money for this, but we got to figure out how to incorporate all of these supplemental benefits, as we've labeled them, into that broader picture of care, because I think that's what's driving the failure to do that, is what's driving a lot of the costs of care.
And I guess one thing I can add is who is not paying for it, are a lot of healthcare plans. And so that would be something we would love to see happen, because it is a huge driver.
I think there's another angle on this, which is which we've seen play out over the last years, is the need to be judicious and stratified and segmented, in those benefits as well. I mean, we saw health plans sort of paint a very wide brush in times of plenty a year or two ago, and then I'm sitting there paying out. I said, well, over these over-the-counter benefits, am I actually seeing improved outcomes, decreased costs from those, and that's sort of a pass-through. Within our model, we had a very universal and global transportation benefit that I don't think we could show the returns on investment that we needed to sustain. And so it goes again to the point of figuring out not all dual eligible patients are the same, not all complex needs are the same. And so how do we align the right incentives, the right supports? And ultimately, that's going to have to come through a caregiver of some sort. An insurance company is never going to be able to know who needs what. And so that's where, again, putting the risk and the accountability closer to the patient getting care as the only solution.
Great discussion. Jen, you have something?
Thanks to all of our panelists for a really interesting discussion. I'm going to direct this question to Olivia first, but would appreciate others' response. So earlier on, our PCDT team presented this model of for serious illness ultimately leading to death, a hard landing versus a soft landing that included palliative care and hospice care where appropriate. So my question, Olivia, is for you. You made a comment around a solution, so I wanted to give you a chance to describe why you think it's an important solution, and that's adding to the MCCM model, allowing patients to choose palliative care in the home without forgoing disease-directed therapy. Can you talk a little bit more about why you think that's so important? And then any other conversation around how do we allow or engage more patients in this opportunity to have a soft landing instead of a hard landing, either with incentives or where appropriate penalties, or what does that look like from a payment perspective?
Thank you so much for that question. Yeah, so MCCM really was a concurrent care model. Interestingly enough, in the time that the program ended and today, we launched a pediatric hospice program. And because of the Affordable Care Act, children and their families who are choosing hospice do not have to forego aggressive measures or disease-directed care. So patients who are on hospice, who are under 21 years of age, can continue chemotherapy, they can continue hospitalizations, whatever it is that they need to do. The benefit is, in many cases, they don't, because they have a supportive hospice team that's coming to their home regularly, often daily. So what's interesting to me is, in the time that we stopped doing MCCM and today, we've actually continued to run a concurrent care model, which is our pediatric program. And in that, you see that while they can continue to do all the things that they want to do to pursue their hopeful recovery, or even just palliative, things like palliative radiation, things that will improve their outcomes and their quality of life, the cost savings was still realized with MCCM because they have that relationship. What we did strategically with the MCCM program is we kept their care team the same. So whether they were on MCCM or whether they bridged to the hospice program, we didn't change the nurse. We didn't change the physician overseeing the team. We didn't change the chaplain. And that was very, very successful. I think at BNA, 75 to 80% of the patients who are on MCCM did go to our hospice program. And again, that's not everyone's goal. And I'm not a proponent of pushing hospice when someone doesn't believe in it, or it's an affront to their cultural beliefs, or they don't want it. However, what was interesting is what happened though is we didn't have to call them or make the visit and say, I think it's time for hospice. We had phone call after phone call after phone call from families saying, I think it's time for hospice. And so through that relationship and that supportive care in the home, they were able then to realize, I think we need more help and it's time for hospice. And the numbers at our organization and the numbers from the final report from MCCM mirrored each other very closely. I attached in the appendix, actually, if you click on the MCCM final report, you can read the whole thing, and it's very brief, but I think that it actually did achieve all the goals of CMMI, the quality outcomes, reduction in cost, patient satisfaction. And to me, when we talk about these complex patients who oftentimes are falling into gaps, falling through the, whatever the word is, the gaps, where they don't have an appropriate roadmap, right, as to how to access the care at the right time, at the right place, in the right setting. And supportive palliative care in the home can meet some of those needs and address some of those concerns because they have someone who's available 24/7. We had an after hours team that was specific for this program that made after hours visits. So it wasn't just a phone triage. If a patient was declining and was on our palliative program, and it is to this day on our palliative program, we send a nurse out to make a face-to-face visit. And we're a small, relative to a lot of people on the panel, we're a small organization, right? We're a regional organization. However, I think we are a good example of what nationwide can be done. The way that we would need to get more hospices enrolled in MCCM, because there was some attrition. It started out with, I think, 140-ish hospices, and then a lot dropped off because the payment wasn't enough. It was $400 per patient per month. I think we determined that anywhere from 600 to 800 would even capture a lot more hospice participation and improve enrollment. But I also think that naturally over time, as supportive palliative care in the community has grown as a program, a lot of hospices, a lot of home healths are now offering that as a service. People are more aware of that benefit. And I think patient enrollment would go up because I think that just like hospice, word's gotten out, this can help you in your home. And so I think that times have changed even in the short period during COVID, but yeah, I would like to really see this relaunched in some form or fashion. And there are things that can be tweaked. One thing is I think we should expand the diagnoses required for enrollment. There were only 4 diagnoses that were accepted. I think that we can expand that some, but I don't think that we would have to raise payment a lot. I think raising payment a little bit would attract more hospices to provide this type of care. Thank you.
I just piggyback. We have a program called One Medical at Home that is a in-home nurse practitioner care model for these patients that we're talking about. But sort of 2 flavors. One, stabilize, and manage multiple chronic illnesses for a prolonged period. We think that we can turn a corner, and then others who are almost certainly going to be hospice appropriate, are going to be hospice appropriate. We don't care differently for those 2 segments, because it's both of them are going to the 4 M's and understanding what's going on, but just the ability to be in home with patients. We have community health workers who are now bringing nurse practitioners in via tablet for some of the intercurrent care, pulling on a theme someone else referenced in terms of just being able to, take our dollar of investment and spread it even further. And these are the conversations we're having. We have very similar outcomes. I'd say where we've had a VBID design that allowed concurrent hospice, or in the CMS program where we're at risk for hospice, I think we've had early signals. But just those programs were too widely spaced, and there wasn't enough density for us to build that real handoff and to know which patients would be able to connect and continue that care on the next step of their journey. I do think the connections back to our primary care teams were super important, because as much as electing for hospice as a sort of decision node and decision point in a patient's journey, just changing the locus of your relationship from your PCP, if you have one, to somebody else who's spending more time with you is also one. And so by being able to bridge that, patients, we do switch the PCP of record in our system to the nurse practitioner at some point, but that's not a force function to start getting those enhanced services, because many patients are connected, and we're able to sort of harness 10, 15 years of PCP knowledge around who the patient is, to support them in the next phase of their journey. But I do think policy solutions that help the next step of the bridge would really benefit us as well.
Matt or Cheryl?
The other thing I will add just very quickly, because I think Olivia and David's responses were perfect. But what's interesting, and I have some incredibly talented palliative care colleagues, but you distill down what is at the core. I just want to make this clear to the panel. At the core of palliative care is taking time with the patient, right? I mean, so yes, there's specific skills, but it isn't so much the program. And I come back to this. It's investing in the time and the relationship to understand what's going on with this individual, what potentially has fallen through the cracks, what didn't get followed up on, how do we educate the patient. So to me, you distill that, it's time. It's creating models that allow our clinicians to spend time with the patient and form those needed relationships. I mean, that's the special sauce.
And then adding to that time is goal-oriented care. So palliative care works because we're looking with the person, not just about or for, but with the person in their journey of care.
Okay, I don't see any other name tags up, but this has been a tremendously robust discussion. We got through one question, which led to a lot of great dialogue and discussion. So we only have a few more minutes, so I want to give the panelists time to tell us, what did we not ask you that's important for you to message to us today before this ends? And so I'll start with David, and we'll work our way around.
Just looking through some of my notes, one area that I'd hope we maybe could talk more about was just health equity and the extent to which total cost of care models for high-risk patients, I think, essentially set up the preconditions to pay attention to that. When I look across my population, it's the underserved and the folks with long held disparities. They're having the bad outcomes that I'm on the hook for. So like it sort of at the base level aligns incentives well to go pay attention to it. And that's necessary, but not sufficient. And we've learned in our early model, we hired health coaches from the community, sort of deeply embedded. And we thought that would sort of by nature, and it did, increase trust, reduce barriers. But we've taken a lot more rigor of late and actually measuring disparities, tracking them, and seeing, yes, one of our programs is disproportionately enrolling patients with, longstanding disparities in care, and starting to see shrinking of those disparities, but another hasn't done enough. It's working for the white wealthier folks among the complex chronic subset, and that's been a really powerful feedback loop to with clinicians and operators who are deeply mission driven, and just putting that data on our face and reflecting back what we need to do better. I think ACO REACH, and just as an example, the health equity plans, the sort of focus around that has been useful. But I think you need to sort of more deeply bring that to the fore of what you're doing.
Thank you. Olivia.
I would echo that exactly. The health, I had written that down as well, the health equity piece. Unfortunately, in hospice and maybe other areas of healthcare as well, you actually are de-incentivized to take care of some of those really complicated patients who don't have a caregiver it can adversely impact your star reporting. It can impact a lot of things because the patients are just much harder. The outcomes may not be as good, but for the patient, they may still be better than if you weren't there at all. And so I think making sure that we don't create more problems with audits and oversight and reporting that make it more difficult to take care of really complex patients. I think that we should incentivize all provider types in some kind of way to take care of patients, even though they are more expensive and they're difficult to take care of. You have to employ much more social work and those kind of things. So I think just making sure that we are giving providers some kind of incentive to take care of patients who historically there are reasons, some of which we've created inadvertently, for why those disparities exist.
Thank you, Olivia. Matt?
I just want to thank you for involving me. I think I learned as much as I offered. The one thing, and I did mention it, but I think it definitely deserves more time, is just the burden around reporting. I've actually been in positions where, as a chief medical officer, I wanted to identify or create quality measures so I could measure, provide. And what I could say is I've never, not once, been humbled by how good intentions go awry very quickly and create burden and inefficiency. So I understand the intentions around reporting and quality measures. I just think we need to be more thoughtful and involve the stakeholders in them. And I think there would be a tremendous amount of waste reduction if we did that effectively.
Thank you. And Cheryl?
I'll try to wrap it up quickly. So in my 35 years, I've seen a lot of really good models, and some of them don't exist anymore. And so I think one of the things that we need to also look at is what doesn't work and why. And so as I look at some of the models that haven't survived, they tended to be local incentives. They tended to be disease focused. They required a local champion. Sometimes that was me. And when I moved, the program went away. And they were episodic typically. So what we are talking about here for success is something that is embedded within the delivery system, that is longitudinal, that is whole person focused, not just a one-off model that's a good idea and then we leave and then we're on to the next thing. So that's my hope for this work, and I remain optimistic.
Thank you for that. Well, I'll tell you, this has been a fascinating session. This has been great discussion, and obviously we picked the right experts to come talk to us, and we really appreciate that and appreciate your time. So at this time, we're going to take a short break until 2:40 Eastern Time. Those that are listening, please join us then. We have our first listening session to discuss best practices for measuring quality and outcomes related to caring for patients with complex disease and serious illness and total cost of care models. So again, thank you, and hopefully you'll stay on and listen. Thank you. See you back.
Produced by the U.S. Department of Health and Human Services.